I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Well, kudos to Dr. Nina Abraham and her expert panel as it relates to the most recent guidelines published by the American College of Gastroenterology in concert with the Canadian Association of Gastroenterology as it relates to the management of anticoagulation and antiplatelet therapy as it relates to acute GI bleeding and also in the periendoscopic period. This is something that's incredibly sanguine to, no pun intended, to day-to-day practice where we frequently will see these patients come in with an acute GI bleed and we'll be in the direct conflict perhaps with cardiologists or neurovascular prescribers of these agents and say these patients came with a GI bleed, we need to stop these therapies. They would say we can't stop these therapies, the risks are too high. And I think the evidence has really evolved in the favor of the latter. And as gastroenterologists and interventional endoscopists, we need to be sanguine to this. So let me put this in perspective. First, as it relates to the guideline points, one is that if the patients come in with an acute GI bleed, reversal of things related to fresh frozen plasma with patients on Coumadin, the recommendation was that should not be done. And this is really something that we've talked about previously as it relates to the patients with cirrhosis. We say fresh frozen plasma really never is going to be helpful in that circumstance, and the evidence really is against that as well. But in the case of these patients who are non-cirrhotic, the recommendation here is the reversal of this with as it relates to fresh frozen plasma, or as it relates to also to the administration of prothrombin concentrate, complex concentrate. These are things that are not recommended. The downstream risk of thromboembolic events was certainly profiled in this review. The recommendation was weak, but the recommendation, again, being said, was against this unless in the face of an active, life-threatening type bleed. And the same as it relates to the antiplatelet agents or the direct thrombin inhibitors, or as it relates to the factor inhibitors. So the use of all these new things we have that we can reverse these things, or even traditional things where we may give them platelet transfusions, recommendation was not to do that either. Again, the downstream risk was felt to be higher. And the patients come in on aspirin, the same thing. Stopping aspirin really in the setting of a secondary prevention risk was something that was not felt to be necessary. And certainly early restart of this is important. As it relates to the prophylaxis going forward in patients with endoscopic procedures, pretty much the recommendations I think reflect current practice, with the exception of warfarin, where they recommended not stopping warfarin, except in the face of a patient perhaps with with a mechanical heart valve, and in that case using bridge therapy, but not using bridge therapy if you decide to stop the warfarin in any other circumstance. So those patients, again, would be referred back to their primary prescriber. And as it relates to antiplatelet interruption versus continuation, recommendation was that brief interruption of these antiplatelet therapies the day before certainly is reasonable. It's not inferior, but again, should be started again with the concert of the prescriber and never interrupted with the absence of the prescriber condoning this before you go forward. And the timing of restarting it, they really didn't give us great guidance. They said 1 to 7 days. The recommendations that I typically will tell my patients is to restart it the day of or the day after, depending on when they take these and what the level of intervention was. But again, these things come back to rule number one is do no harm. So if an acute GI bleed, their thromboembolic risk needs to be weighed against their continued bleed risk, and the same as it relates to the intervention for an endoscopy risk. What I think we're learning more about is the thromboembolic risk, or the embolic risk, is really the most risk. And in particular, in patients that have primary coronary intervention, the most recent data suggests that if a patient comes in within 30 days of an acute stent thrombosis, their relative mortality is approximately 75%. Mortality, not just stent thrombosis. So when we start to do acute GI bleeding interventions in our acute stent patients, we really need to be understanding this. And our cardiologists used to beat us over the head about this, saying, you've got till morning, you can't stop these agents, and we said, well, we just had an acute GI bleed. We as gastroenterologists need to control hemostasis and do as definitive an intervention as we can, but recognize that we really can't stop against the antithrombotic risk prevention as it relates to these antithrombotic therapies for stent occlusion. And that's really important. Recognize the mortality that we just talked about in 30 days is inordinately high for an acute coronary thrombosis for stent occlusion. And it's the same as it relates to anticoagulation. We need to be sanguine about what the relative risks are. So when we start to talk about therapies, I think we need to outline that we can do a lot of these interventions, particularly endoscopic interventions, on therapy. And I find that patients are kept in the hospital for a period of time because they need a Plavix washout or a clopidogrel washout or some form of they're not adequately cleaned by their platelet aggregation, and this is ridiculous. They need to be done as quickly as they can, and they can come back if you have a large scale intervention. If you have a large polyp, you need to bring them back. I outline this to my patients and then say, if we find this, we'll have to bring you back. But I think we can really step up and be more appropriately aggressive in doing these patients on therapy. There is some data that is emerging as it relates to discontinuation of the dual anticoagulation therapy the day of the treatment. This is really particularly an endoscopic treatment. Comes from Japan. I think that data is pretty strong, albeit still preliminary. But as it relates to intervention with cold snare polypectomy, I'm very confident to say we can do these patients more aggressively for diminutive lesions while on therapy. And again, they don't really miss a beat. And it's just something that if there's a mild acute GI bleed, it can be recognized. Flushing it or clipping it certainly precludes most of the ongoing bleed in these patients in the absence of a significant more intervention with clipping or intervention with hemostasis. But I think that there's virtually zero risk for delayed hemorrhage in these patients if you use cold snare polypectomy. So as gastroenterologists, we need to do better. We need to understand that these direct interventions are really a problem. We looked at a couple of years ago with a bunch of national experts as well, the downstream consequences of 30-day admission or readmission or ER evaluation for patients undergoing endoscopic procedures, and found that if they were on antiplatelet or anticoagulation therapy, the odds ratio was increased by about 11 times that they would have to come back within 30 days. And we would frequently not see these as gastroenterologists. They come back to a cardiologist or a pulmonologist or somebody that would hospitalist, and we wouldn't see them as a GI complication, but they really are, that we interrupted the therapy. So again, be aware that we have a significant risk associated with our interventions, and we need to be more aware that the interruption of these antiplatelets and anticoagulations may be a more consequent risk. We need to be better stewards of the risk-benefit assessment for these patients. So please talk to your intervention and prescribers. Don't stop these therapies without their specific input and direction. And hopefully this leads to better outcomes for our patients. So I'm Dr. David Johnson. Thanks again for listening.